In this video, we shall see about the basics of fetal echo. The first thing in fetal echo is we have to determine the situs. The easiest way to determine the situs is imagining ourselves in the fetal position. Here, the fetus is in cephalic presentation. So, this will be the right side of the fetus. This will be the left side of the fetus. Here, we can see stomach on left side, aorta on left of the spine, anterior to this is the spine. This is the anterior abdominal wall. Aorta is seen on the left of spine and IVC is seen anterior to the aorta and to the right of spine. So if we draw a line exactly in the middle, aorta will be left side, IVC will be right side. So abdominal situs is normal. Next thing is we have to determine the cardiac situs. For that, we have to move our probe slightly upwards towards the fetal head. Here we can see the cardiac apex. We can see the stomach, IVC joining the right atrium, and cardiac apex is on left side. So cardiac situs is normal. Next, we shall see about the views of the heart. The five basic views of the heart are four-chamber view, three-vessel view, three-vessel trachea view, LVOT and RVOT. In routine anomaly scan, if we see any abnormality in these views, we have to try and see these views also. That is aortic arch view, ductal arch view and bicaval view. Here we can see the apical four-chamber view. This is the most important view of the heart. Here we can see the left atrium, left ventricle, right atrium, right ventricle, and we can see the descending aorta. This is the spine, this is the anterior chest wall. Certain checklist we have to follow in apical four-chamber view. What is the checklist is? First is the situs. We have already determined the situs to be normal. Then the cardiac axis. The cardiac axis here it is normal. It is measured by drawing two lines. The first line passing through the center of the spine to the sternum anteriorly. Another line passing through the interventricular septum of the fetal heart. These two lines form an angle. It is the cardiac axis. It is roughly 45 degree plus or minus 15 degrees. So if it falls within this range, it is normal. Here it is normal. Then the size of the heart. Here the heart occupies almost 1/3 of the fetal thorax. It is a normal size. Next, the symmetry. Here the right ventricle and left ventricles are almost of equal size. So symmetry is maintained. Next is the squeeze. Squeeze is the contractility of the heart. Here we can see the cardiac atria and ventricles are contracting normally. Then we have to look for AV valve offset. That is, the tricuspid valve is inserted little bit apically than the mitral valve and the ventricular septum. Here we can see it is little bit apical, that is caudal, than the mitral valve. So AV valve offset is maintained. If it is not maintained, and that is it is called linear insertion of the AV valves. Next we have to see for AV concordance, that is left atrium connected to left ventricle and right atrium connected to right ventricle. How we know this? We have to determine the morphological right ventricle for this. Here we can see the moderator band in the apical region of the right ventricle. The inner wall of the left ventricle is smooth, but the right ventricle has moderator band and the apical region. So this is the right ventricle. So right atrium connected to right ventricle, left atrium connected to left ventricle. AV concordance is maintained. Then we have to see the crux, that is the plus right region in the center of the heart at the junction of the interventricular and atrioventricular regions. So in this crux region is lost in cases of AVST or VST in this region or primum ASD. Then we have to look for foramen ovale flap. Here foramen ovale opens in the middle of the interatrial septum. Here we can see left atrium, from right atrium, it's opening into the left atrium. So blood flows from right atrium to the left atrium through this foramen ovale flap. Next most important thing is area behind the heart. This is the area behind the heart. We have to see only one vessel in this region, that is the descending aorta. We should not see any other vessel or any other echolucent structure in this region. If we see any other vessel, that may be dilated azygos vein in cases of interrupted IVC. If we see any echolucent structure other than this and it is not a vessel, we have to rule out esophageal atresia, because esophagus may be dilated and seen in this region in cases of esophageal atresia. And the next most important thing is we have to see two pulmonary veins draining into the left atrium. Here we can see the two pulmonary veins draining into the left atrium. So in cases of TAPVC, we will not be able to see these two pulmonary veins. Instead, this retroatrial distance, that is the distance between the left atrium and the aorta, may be increased. Next view is the three vessel view. In this view, we can see the three vessels arranged from left to right. PAS, pulmonary artery, aorta and SVC. Here we can see the main pulmonary artery branching into left and right pulmonary arteries, then aorta and SVC. They are arranged from anterior to posterior. That is, pulmonary artery will be anterior, next aorta, next SVC, and size also from bigger to smaller. It is little bit big, then aorta will be smaller than the pulmonary artery, SVC still smaller. Then anterior to the vessels we can see the thymus. Here in this video cine clip we can see the thymus and the three vessels. In the three vessel view, if we see only two vessels, that indicates abnormality in the outflow tracts. We have to carefully evaluate the outflow tracts in those cases. Next, if we see four vessels in three vessel view, that will be the fourth vessel will be seen next to the pulmonary artery. Here that can be either one of these, that is, it can be persistent left SVC or it can be the vertical vein in TAPVC. So next view is the three vessel trachea view. Three vessel trachea view, we can see the ductal arch, pulmonary artery forming the ductal arch, aorta forming the aortic arch, and the two unite to form a V configuration. This is the three vessel trachea view, and we can see the trachea. So this is the three vessel trachea view. So in front of the vessels we can see the thymus. Here we can see the SVC, trachea. We should always see the three vessel trachea view with color, and both the vessels show the same color. By moving from abdomen to chest in one sweep, we can see all the three basic views, that is apical 4-chamber view, and then we will get this is apical 4-chamber view, this is a 5-chamber view, get the aorta, this is a 3-vessel view and 3-vessel trachea view and thymus. By one sweep from abdomen to thorax, we can get these three basic views. We have to keep the probe straight and move the probe slightly towards the fetal head. From the abdomen, we have to slightly, on seeing the stomach, we have to slightly tilt the probe cranially towards the fetal head and move the probe slightly cranially. We'll get all these three views. Next is the LVOT, that is left ventricular outflow tract. In this view, we can see the left ventricle is continuous with the aorta. Here we can see the left ventricle is continuous with the aorta. How do we get this view is, if we are keeping the probe like this and we are getting the 4-chamber view, from the 4-chamber view we have to turn our probe 45 degree towards the fetal right shoulder. This is the indicator side of the probe, non-indicator side of the probe. This non-indicator side of the probe, we have to rotate the probe 45 degree to the fetal towards the fetal right shoulder. We'll get this view. What is the most important thing to be seen in this view is, we have to look for septo-aortic continuity. That is, the interventricular septum is continuous with the anterior wall of the aorta. If we see any defect in this portion of the septum, that is subaortic VSD, we should look for defects below the level of insertion of the aortic valve. Above the level of insertion of the aortic valve, we may be seeing a small defect, that is coronary artery origin. We should not mistake that for VSD. We should see the defect below the level of aortic valve insertion. Next view is the RBOT view. In RBOT view, we can see the right atrium, right ventricle continues with the main pulmonary artery, and it is branching into right pulmonary artery, and it is the ductal arch. So RBOT, we can see aorta in the center. RBOT is obtained from the 4-chamber view by rotating the probe 45 degree towards the fetal left shoulder. This end of the probe we have to rotate, that is the indicated side of the probe. Or from the LBOT view, if we turn the probe exactly 90 degree towards the right shoulder, we will get RBOT. We have to turn the probe in the opposite direction from LBOT. We will get RBOT. Next is the aortic arch. Aortic arch, we can see the arch of the aorta with 3 branching vessels. This is obtained by rotating the probe 90 degree exactly from the 4-chamber view. By rotating 90 degree from the 4-chamber view, we will get the sagittal section of the fetus, and we can see the aortic arch here. The aortic arch is seen arising from somewhere from the middle of the fetal heart. If we see here, we can see it's arising from the middle of the fetal heart, and also we are seeing branching vessels. We can differentiate it from the ductal arch, where we can see it's arising from the anterior part of the heart. That is, the right ventricle is situated more anteriorly, so it will be arising more anteriorly. Here we can see the ductal arch arising more anteriorly, and there is no branching vessels also. So we can see ductal arch here. It is also obtained by rotating the probe 90 degree from the 4-chamber view to get the sagittal section of the fetus, and getting this view, we can see the bicaval view of the fetal heart. Here we can see 2 vena cava, superior and inferior vena cava, draining into the right atrium. It is also obtained by the sagittal section of the it is also can be viewed in the sagittal section of the fetus by rotating the probe 90 degree from the 4-chamber view. All these 3 views, that is aortic arch, ductal arch and bicaval view, are obtained by little bit manipulation in the sagittal section. So this is the probe position for viewing 4-chamber view. From this view, 45 degree towards the fetal right shoulder, we are moving the non-indicator side of the probe towards the fetal right shoulder. We are getting LVOT. From LVOT, we are moving the probe towards the fetal left shoulder. That is, we are moving the indicator side of the probe towards the fetal left shoulder we are getting RVOT. Then from the 4-chamber view we are moving the probe, rotating the probe. We are rotating the probe 90 degree to get the sagittal section of the fetus. We will get all the 3 views of aortic arch, ductal arch and bicaval view. The above said positions of the probe are for the fetus in cephalic presentation with dorso-posterior position.